It's a pleasure to be with you. The title of this session is Organization and Financing of Public Health, Part 9, State Public Health Departments. There are no disclosures for this presentation. Objectives include review key points in the federal government's role in public health, review key attributes of state health departments, review common state health department authorities, review the roles of state boards or councils of health, review state and local governance classifications, discuss the importance of collaborations and partnerships, briefly review common services provided by state health departments, review state health priorities, discuss accreditation's role in the quality improvement process. In the last 6 sessions, we've reviewed the federal government's role in the practice of public health. The number of federal departments, agencies, offices, centers, and programs, as well as the number of health problems they address, are enormous and complex. Let's review a few key points. Federal departments involved in important aspects of public health include the Department of Health and Human Services, DHHS, Department of Agriculture, USDA, Environmental Protection Agency, EPA, Department of Labor, DOL, and Departments of Veterans Affairs, VA, and Defense, DOD. Each one participates in some aspect of the 10 essential public health services designed to promote equitable access to conditions that promote health. The original 10 essential public health services framework was developed in 1994 by a federal working group. It serves as a description of the activities that public health systems should undertake in all communities. Organized around the 3 core functions of public health: assessment, policy development, and assurance, health departments and community partners around the nation organize their work around the 10 essential public health services framework. Schools and programs of public health teach it, and the framework informs descriptions and definitions of practice. The framework is also used as a basis of the Public Health Accreditation Board domains. The framework has provided a roadmap of goals for carrying out the mission of public health in communities around the nation. However, the public health landscape has shifted dramatically over the past 25 years, and many public health leaders agreed it was time to revisit how the framework can better reflect current and future practice, and how it can be used to create communities where people can achieve their best possible health. As part of the Futures Initiative, the de Beaumont Foundation, the Public Health Accreditation Center for Innovation, and a task force of public health experts revealed a revised version of the 10 essential public health services on September 9, 2020. As with the original version, the 10 essential public health services was created by the field for the field. The 2020 revision of the 10 essential public health services are listed on this slide. 1. Assess and monitor population health. 2. Investigate, diagnose, and address health hazards and root causes. 3. Communicate effectively to inform and educate. 4. Strengthen, support, and mobilize communities and partnerships. 5. Create, champion, and implement policies, plans, and laws. 6. Utilize legal and regulatory actions. 7. Enable equitable access. 8. Build a diverse and skilled workforce. 9. Improve and innovate through evaluation, research, and quality improvement. 10. Build and maintain a strong organizational infrastructure for public health. Let's continue our review of key points on the federal role in the practice of public health. DHHS is the main government public health agency. Within the DHHS, the CDC is the principal division that produces evidence-based public health information and communicates it to the public and to public health and healthcare professionals. Other DHHS divisions of special importance to public health are the Administration for Children and Families, ACF, Health Resources and Services Administration, HRSA, Centers for Medicare and Medicaid Services, CMS, Food and Drug Administration, FDA, and National Institutes of Health, NIH. Let's now discuss the role of state public health for a few minutes. As described in previous sessions, the primary legal authority for public health in the United States rests with the states. The federal government undertakes extensive public health activities that include the generation and distribution of allocated resources and information, healthcare access assurance, and to a limited extent, regulation and enforcement in matters that broadly affect the country, for example, drug and food safety. States generally have responsibility for implementing public health programs and delivering public health services. The federal government has, for example, established the National Electronic Disease Surveillance System, NEDS, yet state and local entities decide whether they will participate in NEDS or other federal programs and to what degree. Due to variation among state and local entities regarding public health programs and authorities, the Association of State and Territorial Health Officials, ASTO, states that the U.S. public health system is comprehensive yet inconsistent. There is at least one state level government authority with primary responsibility for public health in every state. State health departments are structured and organized in myriad ways, located in different parts of state government, and differ in the extent and nature of the authority granted to them. The structure of a state public health agency refers to the agency's placement within the larger departmental organizational structure of the state. The location of the state health agency will affect how agencies operate in terms of budgeting, decision making, and programmatic responsibility. State public health agencies can either be freestanding, independent agencies or a unit of a larger combined health and human services organization, also referred to as an umbrella agency or superagency. State public health agencies located within a larger agency often reside in that agency with other programs, such as Medicaid and Medicare, public assistance, and substance abuse and mental health services. 55% of state public health entities are freestanding independent agencies or departments, and 42% are units within a larger health and human services organization, an umbrella agency or superagency. The North Dakota Division of Public Health is one example of a public health unit located within an umbrella or superagency, the North Dakota Department of Health and Human Services. Besides public health, other services provided by the North Dakota Department of Health and Human Services include public assistance programs, behavioral health, Medicaid, the state's Children's Health Insurance Program, CHIP, licensing, regulation, and certification of health providers, including behavioral, public health, medical marijuana, and human services. Each state public health unit is led by a state health official, a SHO. In 2016, 66% of SHOs were appointed by the governor, 14% by a parent agency secretary, 10% by a board or commission, and 10% by another entity. In 2016, 64% of SHOs held a medical degree, and 44% had an MPH degree. Once appointed, 74% of SHOs require confirmation by a governing entity. The median tenure for a SHO has been stable at 1.8 years since 2012. State public health departments vary in the authorities granted to them. Most state public health departments, 70%, are authorized to declare health emergencies and to collect key health data. Less than one half have the authority to adopt public health laws and regulations. Less than 30% of state public health departments have budget authority. State public health funding and administrative decisions generally rest with the legislature or executive branch of state government. 27 states have boards or councils of health, which variously promulgate rules and advise elected officials on policy. A minority of state boards of health formulate public health policies, legislative agendas, or public health budgets for the state. Boards of health or health councils are typically comprised of citizens, consumers, members of the business community, healthcare, and public health professionals. Boards and councils of health historically had significant influence on public health activities at the state level, but their authority has been steadily declining as political entities exert more control over public health issues. The relationship between state health departments and local departments exhibits considerable variation. Local public health in the United States is organized in four ways, including decentralized, or led by local governments, centralized, or those run by the state, mixed, where there are some units run by the state and others by local governments, and shared, where all local health departments are governed by both state and local stakeholders through a joint board. This chart shows local public health governance types across the United States. Green represents decentralized states, which includes most states, including North Dakota, Montana, and Minnesota. The yellow represents centralized states, including Arkansas, Mississippi, South Carolina, and Vermont. Blue represents mixed states, including South Dakota and Wyoming. Red represents shared states, including Kentucky, Georgia, and Florida. Most state health departments report partnering with non-governmental organizations, NGOs, on various programs and activities, including universities, colleges, schools, community organizations, hospitals, and community health centers, healthcare providers, insurance companies, businesses, the media, and environmental and conservation organizations. An Institute of Medicine IOM report in 2012 stressed the need for increased collaborations and partnerships to adequately improve public health and wellness in the United States. One of the most used diagrams from that 2012 IOM report is adapted on this slide. There is a continuum of integration from isolation to merger. In between those poles, risk awareness, coordination, collaboration, and partnerships. Isolation means that groups have no idea of what others are doing. Awareness means that groups are cognizant of others, working in common areas of interest, but have no engagement between groups. Coordination, collaboration, and partnerships are defined as increasing levels of working together. Also, as one moves from the left pole of isolation to merger, there is increasing dependence or interdependence of groups on each other. Merger is a state of total immersion and fusion. Isolation and merger are relatively uncommon. Most experts feel that much of what is done currently in integration falls into awareness and coordination, with too little true collaboration and partnerships. Increased collaboration and partnerships are essential to help meet health and wellness goals. A good example of effective partnering and collaboration is the Turtle Mountain Band of Chippewa Indians, TMBCI, COVID-19 pandemic response. The main goal of the tribe's COVID response plan was to reduce COVID-related severe disease and deaths, since the mortality rate for American Indians was expected to be 2.1 times higher than that of the white United States population. The TMBCI Public Health Department partnered with the State Health Department, K through 12, and college leadership, school nurses, TMBCI government leaders, and the Indian Health Service, forming a task force that met weekly to discuss COVID epidemiologic data and develop collaborative strategies. As of September 2022, the North Dakota and United States COVID mortality rates were 2.9 per thousand and 3.1 per thousand, respectively. The TMBCI COVID mortality rate was expected to range from 6.09 to 6.51 per thousand. The actual TMBCI COVID mortality rate was 2.8 per thousand, less than the North Dakota and United States rates and far under the expected rate for a high-risk Native American population. This underscores the effectiveness of public health collaborations and partnerships. State public health departments engage in a wide range of public health activities. Federal initiatives are important for states, as indicated by the number of states participating in the federal initiatives listed on this slide. 98% of states participate in the Maternal and Child Health Title V and the CDC Preventive Health and Health Services Block Grant. 96% participate in the CDC Public Health Emergency Preparedness Cooperative Agreement, Immunization Funding Section 317, and the USDA Women, Infants, and Children WIC programs. Participation in the other 5 programs listed range from 82 to 92%. The main point is that federal initiatives like these provide important impetus and resources for state public health departments. Major public health services provided by states include surveillance and epidemiology, environmental health, maternal and child health, emergency preparedness, immunization services, vital records, regulation, inspection, and licensing, and personal health care. Let's briefly consider each of these for a few minutes. Every state public health department conducts some level of public health surveillance, monitoring, and epidemiological activities. Almost all state public health departments collect and have access to care data. 96% of states collect and epidemiologically analyze data on behavioral risk factors, communicable and infectious disease, state determined reportable diseases, and vital statistics. The American Public Health Association executive director, Georges Benjamin, stated, many communities lack access to nutritious, affordable food, are denied safe places to walk and exercise, or live near polluting factories. The health risks for these families are greater. We support research and action to help ensure healthy environments for all. Environmental health is the branch of public health that focuses on the relationships between people and their environment, promotes human health and well being, and fosters healthy and safe communities. The field works to advance policies and programs to reduce chemical and other environmental exposures in air, water, soil, and food to protect people and provide communities with healthier environments. Environmental health is a key part of any comprehensive public health system. 90% of state health agencies oversee environmental health epidemiology and food safety education, with many state health agencies involved in toxicology, radiation, radon, poison, vector control, indoor air quality, and water supply safety. Regarding maternal and child health services, approximately 80% of states offer services to children with special health care needs. 57% of states administer the USDA Women, Infants, and Children's WIC nutrition program and provide family planning and prenatal care services. About half of all state health departments are involved in early intervention services, including home visits to improve maternal and child health. All state agencies have some responsibility to prepare for disaster response and emergencies. All state health departments have responsibility for responding to communicable disease outbreaks. Nearly all have responsibilities for responding to bioterrorism events, and almost 90% have responsibility for responding to chemical, nuclear, and natural disasters. Over 90% of state health departments are responsible for vaccine ordering and inventory distribution of childhood and adult vaccines. Approximately 46% of state health departments administer childhood and 42% adult immunizations. Vaccine administration depends on the state's public health infrastructure. 85% of agencies in centralized states provide childhood and adult vaccine administration versus 22% in decentralized states. In decentralized states, vaccination services are usually provided by primary healthcare providers and or local health departments. Most state health agencies have some involvement, along with other agencies at the federal, state, and or local level, in the regulation and enforcement of laws that protect health and ensure safety. Activities include inspection or licensing of a variety of public health system partners, such as entities that provide direct care, including hospitals, 42 states, clinics, 23 states, and hospice facilities, 36 states. Other activities include regulation, inspection, and licensing of entities that process and serve food, recreational sites such as beaches, campgrounds, and public swimming pools, water sources, waste disposal sites and entities, and tobacco retailers. Fewer than 25% of state health agencies directly license nurses, physicians, physician assistants, or dentists, which typically is a function of another agency or organization like discipline specific state boards of examiners. Vital records include births, deaths, terminations of pregnancy, marriages, and divorces that are initially registered locally in 57 vital registration jurisdictions in the United States. The 50 states, 5 territories, Puerto Rico, U.S. Virgin Islands, Guam, American Samoa, and the Northern Mariana Islands, the District of Columbia, and New York City. Each of the 57 jurisdictions has a direct statistical reporting relationship with the National Center for Health Statistics, NCHS. Some of the states have centralized vital records offices that may be located within state health departments, but most have local registrars who receive, register, and issue certified copies of vital records. There are over 6,000 local vital registrars nationwide. Except for HIV/AIDS and STDs, state health agencies generally do not provide treatment for communicable and chronic diseases. Approximately 60% screen for tuberculosis and STDs, including HIV/AIDS. Over 70% of agencies provide newborn screening services. The frequency of screenings for breast, cervical, colon, and rectal cancers are dependent on the size of the population served. A minority provides services for victims of sexual assault and violence, substance abuse prevention, or pharmacy services. Agencies in centralized states provide these services more often than those in decentralized states. Most state health agencies provide or regulate at least some clinical services in oral health, emergency medical services, minority health, and rural health. In 2017, state public health officials listed 5 priorities. 1. Improving public health and public health infrastructure. 2. Assurance of access to healthcare systems and services. 3. Increasing the availability and use of data and evidence. 4. Quality improvement, performance management, and accreditation related services. And 5. Implementation of effective health policies. Related to quality improvement and effectiveness is a growing interest among state health departments in accreditation. The Public Health Accreditation Board, FAB, accredits public health departments to strengthen public health infrastructure and transform governmental public health. This is a voluntary activity. The 3 prerequisites for submitting an application for FAB accreditation are: conduct a state health assessment, create a state health improvement plan, and develop an agency-wide strategic plan. As of 2016, 40% of state health departments had received accreditation. Most of the services provided by state health departments fall under the 10 essential public health service categories. 1. Assess and monitor population health. 2. Investigate, diagnose, and address health hazards and root causes. 3. Communicate effectively to inform and educate. 4. Strengthen, support, and mobilize communities and partnerships. 5. Create, champion, and implement policies, plans, and laws. 6. Utilize legal and regulatory actions. 7. Enable equitable access. 8. Build a diverse and skilled workforce. 9. Improve and innovate through evaluation, research, and quality improvement. 10. Build and maintain a strong organizational infrastructure for public health. In summary, The Department of Health and Human Services, DHHS, is the main government public health agency. Within the DHHS, the CDC is the principal division that produces and communicates evidence-based public health information. The U.S. public health system is comprehensive yet inconsistent. State public health funding and administrative decisions generally rest with the legislature or executive branch of state government. The relationship between state health departments and local departments exhibits considerable variation. Increased collaboration and partnerships are essential to help meet health and wellness goals. State public health departments engage in a wide range of public health activities. The Public Health Accreditation Board, FAB, accredits public health departments to strengthen public health infrastructure and transform governmental public health. Most of the services provided by state health departments fall under the 10 essential public health service categories.